Welcome everybody. Why don't we go ahead and bring up our slides? I just had a handful of slides I wanted to share to provide everybody an update on where we are with our efforts to serve the state as a third-party administrator. We can go to the first slide. The question I get a lot is why is Blue Shield doing this? And the simple answer is that we felt like we could help save lives. And this was at the core what we want to do as a nonprofit mission-driven company. And the thing that we think we can do best to help is to make sure that the state, all the local health jurisdictions know where the vaccine is at all times, from the moment it's allocated by the federal government to the moment it's injected in somebody's arm. If you can move to the next slide, please. We've had a chance to speak with all 61 local health jurisdictions, most of the providers that are vaccinating currently, many people within state and local government. And our reflections are there's a lot of things that are going well. Really impressive mobilization and efforts by local health jurisdictions, getting robust networks and equity plans in place, great capacity and reach in those networks, a great willingness and eagerness to administer vaccines, incredible dedication from people across the spectrum to make this work. And we've seen an increased rate of vaccination as the supply has gone up. The big thing we're in right now is a supply constrained environment. The biggest need we have is more vaccine, but also more predictability and stability throughout the system as to how much vaccine is going to go where, when, the ability to keep score, I think deliver on equity aspirations and get the coordination, communication, and alignment between federal, state, and local better. When we talk about equity, this is probably not an audience I need to spend a lot of time on. Obviously, our performance there has been uneven. No system is going to be perfect, but I think we all know that we have a gap between our aspirations and where we need and where we are currently in terms of delivering on equity. Let's move to the next slide. Want to spend a little time on this one. In the white section from the black line to the left, these are all actual doses allocated by the federal government to the state of California. They exclude direct federal allocations to programs such as the FEMA mega sites and the pharmacy direct allocations. To the right of that black line are forecasts. The first few weeks are forecasts that we actually get from the federal government, California gets. And then beyond that, they are my attempt to take the guidance that we've heard verbally about how much national supply will be available when, and assuming California's prorated share of that vaccine. The orange line are first doses, the blue line are a combination of first and second doses. So what you can see here is we're a little over 1.6 million or so doses that we have been allocated to California in our most recent cycle. Those are both first and second doses. And you can see for the next few weeks, for the balance of March, that is not going up much. We received about a 4% increase in first dose allocations in this last round, and we're not anticipating, based on the guidance we've heard so far from the federal government, that increasing very much. But they are expecting a bigger increase come the very end of March or early April, particularly in the form of expanded Janssen supply, but also an increase potentially in Pfizer and Moderna as well, which means that we have the potential here by the time we get into April to go from a little over 1.6 million doses to over 2.5 million doses. So if we can go to the next slide. So bear in mind as I go through this that the 1.6 million number, which was the latest weekly allocation that the state got from the federal government. This chart, the first blue box, highlights the number of contracted providers, those that have contracted with the third-party administrator, and their vaccine capacity, which is about 2.6 million. We're in discussions with other providers to deliver potentially an additional 2.2 million. And the local health jurisdictions themselves and some of the large mega sites, some of which they're administering and some of which others are, deliver another potential 2.7 million. So the capacity that we're looking at right now is quite vast. It's about 7.6 million doses per week. And there's frankly more than that that could be built out or accessed. And we're currently at 1.6 million. And our projection and what's in our agreement with the state is that we believe probably the largest number we'd get on a weekly basis from the federal government is around 4 million doses. So you can see that capacity is just not an issue. There's plenty of it out there. We are more supply constrained. You can also see on the left-hand column with the 298% that we are measuring access statewide in every geographic area overall, and also in the lowest quartile healthy places indexes locations. And you can see that this is with already contracted providers. We've got pretty good coverage. So getting a network in place that can handle the capacity and provide coverage is really not an issue. If we can move to the next slide. We're also doing a lot of onboarding onto the performance management system, which includes MyTurn. This is a running list and it's growing every day of those that have been onboarded. And just a quote from one of the players about how easy it was to get onto MyTurn and how they were planning to tell their peers about it. So, you know, the integrations and the onboarding of the contracted providers onto MyTurn is going well. And more than half the local health jurisdictions, there's 61 of them, more than half of them are now either on MyTurn or have committed to be on MyTurn in less than a week. And most of the rest are actually in discussions about when their date may come to move on to MyTurn. If we can go to the next slide, please. So I get asked all the time why I think this is going to work. I think the answers are pretty simple. This performance management system is very simple. There's the number of data elements we're looking at and that are captured in something like MyTurn is very small and straightforward. The workflows are pretty straightforward. The technology that's there to support it is working. It's functioning as designed. We've done end-to-end testing on data integrity and feel very good about the system's integrity and its scalability and flexibility. And it's also rapidly evolving. The MyTurn team is doing at least once a week releases of new functionality, and typically more like 2 or 3 times a week, additional functionality onto MyTurn. And the integrations so far, particularly those with electronic medical records, have gone smoothly. I think the other thing is that there's a lot of alignment as I go out there and talk to everybody. Everybody just wants us to get to herd immunity. We all want to make sure that we get folks vaccinated. So the macro goal, there's a huge amount of alignment with everyone. And as I showed you in the chart, by the month of April, we should see a pretty big increase in supply. So for all those reasons, I think we're really set up well to have a successful effort. If we go to the next slide, the last thing I wanted to mention is just what you can expect, which is getting all the contracted providers onto the performance management system, which, as you saw in a prior slide, is going quickly and well. Getting out performance management reports that'll be available as we onboard folks. There will be data on the performance management system to share. The transition to a direct allocation is important, and that's going to happen during the month of March. And then getting multi-week guidance out to those who are vaccinating, the local health jurisdictions and the large providers, on what they can expect in terms of vaccine. And then finally, continued expansion of the functionality of the performance management system, which includes MyTurn, and then of course MyCAVax is the system to do vaccine ordering. So I know we wanted to leave time for questions. Just wanted to give that in the form of an update, and we'll turn it, Matt, back to you.
Thank you, Paul. So we are going to get to as many questions as we can. If we run out of time and we are unable to get to your question, you can email us at media@blueshieldca.com. So here's the first question. And by the way, just in the interest of time, I will try to group some of the similar questions together. So last night, President Biden announced he wants to make all adults eligible to receive vaccines by May 1st. Is that possible here in California? And will we have enough doses and capacity to deliver vaccines to all adults?
Well, if President Biden and his team can deliver the supply, we're ready for it.
The next question, and actually there are several of these, has to do with the counties. And let me get this. So what is the impact of only of the counties being reticent about joining the statewide network? Do you expect counties to sign a separate agreement with the state? And if that's the case, how would that affect the TPA's ability to have a statewide system?
Well, the state is currently in discussions with the counties about signing a memorandum of understanding with the state in lieu of a contract with Blue Shield. There was some concerns about the government entity signing a contract with a private company, any private company. And so they're much more comfortable with an agreement with the state, which is fine by us, as long as there's agreement that they will participate in the performance management system that allows us to deliver on the performance in our contract. It should be just fine. And my expectation is that'll all get worked out here pretty soon for the reasons I mentioned, that it's a relatively straightforward process that can be supported and avoid disruption, and that everyone's got the same macro goals. Everyone's really trying to row in the same direction. So I think this is going to work out pretty soon.
And here's a few questions, I think, coming out of the news conference that just completed with the state. The state today announced 2 million doses having administered to lowest quartile communities. The question is, are we moving fast enough? What is Blue Shield as the state's TPA doing to address vaccines for minority and underserved communities?
Well, we have literally met extensively with every single one of the 61 local health jurisdictions, and I have been in the vast majority of those meetings personally. And a part of that process is for each local health jurisdiction to have an equity plan about how they're going to take these additional allocations for lowest quartile healthy places index tracks, how they're going to get to the populations that are most vulnerable, highest risk, highest to reach, those that have maybe the greatest vaccine hesitancy, and what can we do to support it. And there's a number of examples that we've put in place about how we can support it. For example, in Fresno County, they had particular communities, relatively small in population, agricultural communities, where they needed mobile capabilities to establish a fixed clinic for a day or two a week, and then have it move around to about a dozen communities in Fresno County. So we have set that up as a part of our transition plan with Fresno County. So I don't think we're ever going to be satisfied, frankly, with our performance on equity. We're just going to continue to drive, but we are working very closely with the California Department of Public Health, the local health jurisdictions who've developed detailed equity plans, understanding how we can support them to make sure that they actually deliver.
And Paul, there's a follow-up question along those lines. Has to do with the counties and whether they sign with the TPA or the state. How would that affect allocation?
Sure, the state makes the decisions on allocations. That they're always going to make the decision on allocations. That's a public service that needs to be done by a government entity. Blue Shield of California is making recommendations to the state on those allocations based on two things. One is what they say are their priorities. And so we try to help facilitate their decision-making process by translating their preferences into how that vaccine should be allocated by geographic area. And then secondly, providing input on performance. So if, depending on where providers are in the network and how they're vaccinating, how effective they are they helping with the equity plans? Are they delivering on that? For example, that would be a major part of the performance assessment. So that's the way. So whether or not, that I would see all of the local health jurisdictions ultimately signing a memorandum of understanding with the state And as a result, I wouldn't see that being a factor in the allocation process. I think the factors are going to be what the state's priorities are in terms of which populations they prioritize first, second, third to get vaccinated. That will influence where the vaccine goes. And then the actual performance on the ground and the work we do with the local health jurisdictions is going to be an influencer as well.
And we have a few kind of more broader questions, Paul. It has to do with, what value proposition, does Blue Shield bring to counties and communities that have already set up, network and doing the work of vaccinating in their communities?
Well, the biggest thing is we can optimize the supply of vaccine we get to the state and thereby optimize the vaccine that gets to each local health jurisdiction by knowing where the vaccine is at all times. And we can also make sure that vaccine is getting to the right place at the right time so that the performance on the ground is the best it possibly can be. Having that kind of system in place is really helpful. And we've already seen the results of it. You've seen a cascading effect. The state did not have up-to-date, accurate inventory numbers by individual provider and hasn't up until this point. And as a result, some of the big providers like the University of California and Sutter started to run out of vaccine and were not getting allocated doses by the state at the level that they needed to fulfill second dose appointments because the state in their data thought that those organizations had a lot of inventory, but in fact they didn't. And so when we discovered that was the case, we ended up trying to give a lot more doses to those organizations to honor those appointments. But in the meantime, that actually created some shortages in other places, like Santa Clara County ended up getting fewer doses than they were expecting of Moderna. And then they had a second dose shortage. And so the ability to know where the vaccine is at all times, know what the inventory is with each provider, allows for a much smoother, more predictable, manageable system that can optimize performance and also demonstrate to the federal government that California is doing a great job and should get more support.
Kind of along those lines, you mentioned some of the large systems that are in the network. What about community clinics, or again, better access to hard to reach populations such as farm workers, the homeless, people who are homebound? What are some of the solutions that Californians should be looking for in the coming weeks?
Well, it's high priority for us. We've signed over 40 federally qualified health clinics based on my last report already. That number just goes up every day. In each of our conversations with the local health jurisdictions, we're asking them, who are your key providers for your equity plan? Because we want to prioritize them first to make sure that they're signed up, they're onboarded, they're ready to go, they have the support that they need. And there will be financial support for those organizations as well to support them moving on to this performance management system and vaccinating at the best level that they can. So, this is a high priority in the process, and you can see even by the providers that we've signed up that there's a lot of them that fall into making a major contribution to the equity plans for local health jurisdictions and for the state.